Thanks, Margaret, for the introduction. I want to thank the organisers in inviting me to speak. I feel very privileged. Just to start by saying, if those of you who have not been to London, the Royal Free Hospital is in a little leafy suburb in North London. And those of you who've been to London might know that Hampstead is famous because it was former home for Judy Garland, Elizabeth Taylor, Gwyneth Paltrow, Keats, D.H. Lawrence, and Sigmund Freud. So it's actually quite a famous place. But most importantly and pertinent for today, actually it was the first female medical school in the UK, if not the world. So I'm very, very proud to be part of the Royal Free, as my colleagues have for 20 years. So I work at the Royal Free Hospital and I run a cardiology clinic. I was invited about 10 years ago. And really, as the awareness of cardiovascular disease was beginning, I don't have any commercial or clinical conflicts, but having listened to Luxie's talk, my internal conflict is that I'm an aging cardiologist who's in denial. So, right, so the scope of my talk, and I'm going to take you on a cardiovascular journey, if you like, and I'm going to just start with the epidemiology and how this has landed. I'm going to talk about risk and what that risk is for a woman living with HIV. I'm going to talk a little bit about pathogenesis. You've heard quite a lot about inflammation. I'm going to talk about and pick on sex-specific disease mechanisms relevant to women. I'm going to talk through the clinical manifestations of cardiovascular disease, and this is a big area, and I will highlight one or two areas. I'm going to talk about the risk, where we've been on the journey of risk assessment, where it has arrived, and finally land at intervention. So it's quite clear that cardiovascular disease is a significant cause of mortality and morbidity. And this large European American cohort, we know that 16% of deaths, non-HIV related deaths, are going to be due to cardiovascular disease. Now, this is non-contemporary, and if you look forward to 2020 to 2030, it's estimated that 20 to 30% of deaths in people living with HIV will be due to cardiovascular disease. So it's massive. And after very soft signals, but really not with very low event rates in this journey, what landed was a recognition that there was a significant increased risk of cardiovascular disease by having HIV. And this seminal meta-analysis by Islam, which you're aware of, showed a risk ratio of 1.61 without antiretroviral therapy, and rather alarmingly, a risk ratio of 2.0 on antiretroviral therapy. But this was in the context of cardiotoxic PIs, which augmented and accelerated risk. This was a US meta-analysis with large number of patients, and this was then replicated in sub-Saharan Africa and Asia Pacific with 79,000 patients, actually 793,000 patients over 26 years. And this meta-analysis landed a risk ratio of 2.16. And there was a threefold increase in incident cardiovascular disease during this period. And with respect to women, there was an early signal. This is the Monica-Aproco cohort data back in 2003. There was a signal that women were more likely to die of myocardial infarction. And actually, this showed in young women, 35 to 44 years of age, there was a 59% risk of incident myocardial infarction in women compared to a 20% increased risk in men compared to non-HIV patients. So there was a very early signal, and it was unclear why. Then in 2007, this is a Boston cohort study. This looked at 3,851 patients with HIV, and there was a significant increased risk of myocardial infarction in women compared to men. So a risk ratio of 2.98 versus 1.4. And this had been adjusted for hypertension, diabetes, and hyperlipidemia. But one of the flaws is there was incomplete smoking data in this study. And then furthermore, in 2014, this was looking at HIV infection and cardiovascular disease in women. This was a veterans aging cohort study with 2,187 women. And there was a primary outcome of acute MI, unstable angina, ischemic stroke, and heart failure. And a third of the patients were on antiretroviral therapy at baseline, and another 55% were on treatment after a median of 1.14 years. To follow up to 6 years, and it showed a risk ratio of 2.8 for women with HIV versus not women without HIV. And women were getting CVD events earlier and younger. And that was despite an equal Framingham risk score. Then very contemporaneously, this is 2023, this is a market scan commercial health insurance database. So this is based in middle class people who can afford health insurance in the US. So we've got to be mindful of this. But this did not show an increased risk of MI in women versus men, but it did show an equal incidence of stroke and low limb extremity disease, peripheral vascular disease. And although the risk of MI in women was lower, what was interesting, if you compare women with HIV to women without HIV, that protective effect of particularly female sex was lost in this study, which is, I think, a really important signal. But the problem is that this study did not include people from a low socioeconomic background. It did not include people, many of the patients we see who live in poverty and social deprivation. So what about the pathogenesis? So we understand that the pathogenesis is related to virus-related mechanisms. We know that HIV is pro-inflammatory, it's cardiotoxic, and CD4 plus T-cell depletion is important. Microbial translocation and inflammation is important, and monocyte activation is probably the cornerstone of what happens next. And we also have recognized disease-related, drug-related mechanisms, including cardiotoxicity with the PIs, and more recently, and you've heard some data around the issue of ART initiation, maintenance, weight gain with more recent drugs such as integrase inhibitors. So this cartoon really summarizes the pathogenesis. So the monocyte is really the key player. Monocyte activation is key, resulting in vascular inflammation, adhesion molecule expression, translocation, and then the acute event, the plaque rupture, which you've seen in the cartoon previously. Now, if we focus on sex-specific disease mechanisms, for women, what's pertinent is metabolic dysregulation, which is significant. Inflammation, and I'll hopefully convince you that inflammation is a bigger problem in women than men. Early reproductive aging, you've heard about subclinical atherosclerosis, plaque formation. There is data showing that women are more likely to have microvascular dysfunction in the coronary flow reserve. And also, I'm going to briefly touch on co-infection, which is also an accelerometer. So this study by Conley in AIDS in 2015 shows that obesity is associated with greater inflammation. So you get both increased soluble IL-4 and SCD163, which is a soluble marker of monocyte activation, but you actually have increased activated monocytes in the circulation. And if you look at comorbid conditions in the sex in patients with HIV, this study showed that actually women 50 to 64 years of age were much more likely to be obese. They're much more likely to have hypertension, more likely to have high cholesterol levels, and women aged over 65 are more likely to have diabetes and high cholesterol levels than men. So, and we've seen these signals replicated in Reprieve in the data you've just seen. But more importantly, women have more immune activation, and not only immune activation and inflammation in real time, but they also appear to have a heightened immune response. So this study in PLOS1 published in 2013 showed increased levels of monocyte activation, T-cell activation, microbial translocation with lipopolysaccharide and cytokine expression. And the study in 2014 looked at innate immune response, and women with HIV infection appear to have a heightened innate immune system activation, probably through activation of specific toll receptors. My pointer is not, now it's working. Now, if we look at atherosclerotic plaque, particularly soft plaque and immune activation, this study, this is quite a novel study, compared men and women, and actually in the presence of soft plaque, women had more monocyte activation than men, which is important and interesting. And if we talk about co-infection, hepatitis C, as we know, is a very important infection which coexists with HIV. And actually, hepatitis C independently increased risk of cardiovascular events with an odds ratio of 2.32. We'll come back to that. Now, this is some data which my PhD fellow, Gavin, who's now in Australia, did in collaboration, and this is using a proteomic assay. So we were really interested in low-risk patients, so we took 23 African women living with HIV, and we took 22 controls from our gynecology clinics. They were all young. The average age was 40, and importantly, they were naive to statin therapy, they were normotensive, they were non-smokers, and they all had to be on stable HIV drugs with good compliance for 5 years. So we took a pure group, and we did proteomics and metabolomics. And what was shocking is that in the women, all these proteomes lit up with such a small sample size. And these proteomes express the proteins for inflammation, oxidative stress, apoptosis, endothelial cell activation. And the DEC1, which is very important, fatty acid oxidation, was reduced. And that's very, very, very pertinent to metabolic syndrome we see in women. So in terms of clinical manifestations, coronary disease is more than that. I live and breathe coronary disease, unfortunately, day and night. We published some time ago quite interesting phenotypes, which I hadn't seen in young people. And we described an aneurysmal large vasculitic type phenotype on the left, an atherosclerotic phenotype, and this appears to occur 10 years early, and actually thrombotic phenotype. That patient on the right was from Zambia. He was 29 or 30 years of age and presented with a heart attack. And I had to suck this clot out of his left anterior coronary artery, which was shocking. Heart muscle disease is very important, and actually is overrepresented in women and under-recognized. So you'll see there are 4 echocardiogram images. The top 2 have patients with what we call preserved ejection fraction, but have heart failure. And we used to call this diastolic dysfunction, and this is an abnormality of relaxation. The bottom 2, the bottom left, shows a patient who has severe LV dysfunction, but a very thick, chunky ventricle, and this is hypertrophy. And we have recognized hypertrophy due to fibrosis, not related to hypertension, but also related to hypertension. And this is really interesting, and I'll show you some data as to why this might be. And then the bottom right is a patient with what we call a dilated cardiomyopathy. And I've seen the whole spectrum of heart muscle disease in women, particularly with HIV. I have very few men who have cardiomyopathy. Now, to support the statement that women are at more risk of heart failure, this is the HIV heart study, which was published and in 2022, relatively recently, and what it shows actually in people living with HIV, women have a risk ratio of 2.48 compared to men. So the clinical signal I'm seeing appears to be true in studies. So why do you think women, what is the pathogenesis, what is going on? So this is some work we've done with MRI scanning. MRI scanning, we always show lots of lovely images, but essentially what we're finding in women with HIV is we're finding increased LV mass, we're finding increased T1 signaling, and that represents diffuse myocardial fibrosis. And we find increased T2 signaling, which represents myocardial edema inflammation. And we've seen this across the board, even in women who don't actually have overt heart failure. And this is all supported by other more recent studies that there is this signal of inflammation in the heart, fibrosis in the heart related to HIV. Now, what about hepatitis C? Well, hepatitis C also seems to augment risk with respect to LV dysfunction, and actually hepatitis C alone or co-infection with HIV seems to increase the risk of both diastolic and systolic dysfunction. Right, I've gone forward. I need to go back, sorry. Right. AF. So AF is a very important arrhythmia, and we recognize that AF is increased in patients living with HIV by has a ratio of 1.6. There's not any literature showing a clear difference between men and women. Sudden cardiac death is also increased, and this is shockingly so. This is up to 4.5-fold increase in sudden death, and that's not really understood, but it's probably related to myocardial fibrosis and arrhythmia generation. So we're going to talk about risk assessment in the last 5 minutes and intervention. So as you all know, that conventional risk assessment tools have underestimated risk in HIV, and I think that's accepted. If you remember, the DAD study attempted to risk assess incorporating particularly protease inhibitors, and was sold as a tool to better assess risk, and there may be some truth in that. Conventional tools do not, however, incorporate modifying risk factors such as prolonged viremia, non-compliance, recreational drug use, premature menopause, and I haven't even mentioned there things like social deprivation and access to healthcare. And actually, there are no specific guidelines for women living with HIV. So prior to Reprieve, what were the guidelines telling us? So the European Society of Cardiology Guidelines 2020 suggests that we should treat people living with HIV as high risk, and we should treat to a lipid level of LDL less than 70 milligrams per deciliter, which is the high-risk target for secondary prevention. An AHA statement in 2019 talked about amplifying risk by 1.5 to 2 in the presence of enhancing risk factors such as prolonged viremia and fatty liver disease. And in the UK, our British HIV Association guidelines suggested adjusting the risk factor by 1.6, but then that was subsequently removed due to lack of evidence. These are the joint AHA ACT guidelines, and in the box, I'm sorry it's small, but what it says is that basically if you have a 10-year risk of more than 7.5% using the ASCVD US calculator, then you should be deemed high risk, and you should have lipid-lowering therapy, lifestyle approach, and the choice of those 3 drugs which you've already seen in the last presentation. Now, risk assessment tools, have been applied to a general population, and there are, in my view, significant flaws with them. They tend to be simple, like the SCVD risk, and the European EST calculator is also very, very simple. In the UK, we've attempted to have some risk stratification based on other risk factors. You'll see we have Q risk 1, 2, and now 3, and what it did, it includes things like rheumatoid arthritis, SLE, severe mental illness, psychotic medication. Interestingly, these are inflammatory augmenters of risk. And just to share with you, HIV narrowly did not get into QRISK-3. Why? Because it was not statistically significant due to systematic underreporting of HIV diagnosis through primary care. And there's a whole narrative around this, but actually it probably should have been in there, but it's not. And that is the fundamental flaw with our current risk assessment tools. The other thing to say is that the definition of high risk varies. They're not all the same. So Framingham and QRISK-3 UK talk about 10% as a high risk delineator. The DAD use high risk as more than 3.5%, and the ASCVD talks about 7.5%. That's how they define high risk. We've done some work comparing ASCVD to QRISK-3, and actually QRISK-3, our risk is about 20%. We have a percentage term higher than ASCVD, and that confuses things. Now, this is an abstract in Beaver, actually 10 years ago, looking at how the Framingham versus QRISK-2 versus DAD compare. And in essence, what Framingham does, it misses patients with low risk. It's totally useless at discriminating people at low risk, which actually we need to do. And DAD massively overestimates low-risk patients. So we have a lot of flaws in the current tools we have. So going to intervention, and I apologize, we've got 1 minute, and hopefully I can have 2 or 3 minutes more. Just to rehearse the findings of Reprieve, which has really put statins the cornerstone of prevention in terms of pharmacological prevention. And just to remind you, 7,000 patients, 1-to-1 randomization to pitavastatin, a medium-intensity statin versus placebo. The median ASCVD risk was low. Well, it's intermediate, 4.5%, but very low compared to other statin studies. And the median age of these patients was 50. And there was a 35% reduction in MACE. You've heard of the definition of MACE. There was a staggering 46% reduction in acute myocardial infarction. That is huge. And actually, the reduction of 35% was well beyond, it was 17% was anticipating using extrapolation of previous statin primary prevention trials. It was well beyond that. And probably the reason for that is because my view is that risk assessment tools are flawed. Basically, just keeping this really simple, the risk assessment tools which we've obsessed about are all flawed for our population, okay? So other things in the CT sub-study, 700 patients, a 7% reduction in non-calcified plaque volume, so statins do reverse plaque, and a third reduction in plaque progression. So statins do stuff beyond lipid lowering, yeah? And this has been replicated in a number of studies now looking at moderate intensity statins. So they are good guys. And there was an inflammatory biomarker study with a significant reduction in lipoprotein phospholysis A2, oxidase elder, and hsCRP. These are biomarkers which predispose to acute myocardial infarction and stroke. Now, with respect to what was answered was the question about, do women have more or less plaque? Women had significantly less plaque than men, which is kind of expected because there are studies suggesting more or the same. But what's interesting in the female subset, there was higher levels of IL-6, hsCRP, and D-dimer, which fits with the data I've shown. But interesting, D-dimer strongly correlated with the presence of what we call vulnerable soft plaque. These are plaques which are soft, they have a deep lipid core, are more likely to rupture and cause myocardial infarction. So, the fountain of youth. So, does it lie in statins? Well, possibly, but I would put it to you that this is only part of the equation, yeah? And lifestyle. We need to really embrace this in the patients we treat in our clinics and in the community. And I put this in because there is a discussion about weight and hypertension. And actually, if you look at the interventions which reduce blood pressure, in fact, aerobic exercise and actually fruit and vegetables have a greater impact than weight itself. So actually, we need to focus on diet, nutrition, and exercise. And the graph on the right, I think, is really, really staggering. This is the relative risk of cardiovascular disease by dose of physical activity. The line at the bottom is females doing high intensity activity per week. There's a 50% reduction in risk of CVD, 50%. So yes, statins, let's embrace them, but actually let's not forget we've got a hell of a lot to do with lifestyle, okay? So what do I do in my clinic? So I'm quite aggressive, so I get the patients who have a 5 to 10% risk who are in the intermediate group. I throw the book at them in terms of lifestyle, smoking cessation clinics, try and encourage weight loss, and I also measure HbA1c, and I have a very low threshold for starting a drug called metformin. And there are guidelines to start metformin in prediabetes, and I will treat to a blood pressure of 130/80, which defines pre-hypertension, but in America defines hypertension, and I'll put them on the statin. And that 10 to 20% risk, I'll do an echo and an ECG on all of them and do the same. And I will also do 24-hour blood pressure monitoring for blood pressure assessment. I do not rely on clinic blood pressure, and I'll also do urine albumin-creatinine ratio. And very high risks, all of them get a CT scan, and they get, and most of them get aspirin, and high-dose statin. I aim for the 70 milligrams per deciliter, although in Europe we're now aiming for a cholesterol of LDL of less than 50 now. So 1.4 millimoles per litre, less than 50 is the target. So that's what I do. And in women, special considerations, we need to escalate risk. We need to think about premature menopause. We need to think about HIV, compliance, hepatitis C, co-infection, and exercise, diet, and weight loss. So in the last 30 seconds, I'm sorry. So what's out there beyond statins? So in CROI, you've heard of semaglutide, the injection. The Hollywood actors are taking them. It reduces, in HIV, it reduces lipohypertrophy and fatty liver. On the right is a 22-patient study of canakinumab, which is IL-beta-1 receptor antagonist, reducing aortic inflammation in HIV. Very exciting. So that is my last slide. Thank you very much. I hope I've convinced you that women are at significant risk. the denominator, I think, is inflammation and metabolic dysregulation. They have a higher risk of MI, I think that's than men, and there's a lot we need to do in terms of early diagnosis. I talk about deep cardiovascular phenotyping, individual risk assessment. Statins are here to stay, but actually lifestyle, weight loss, exercise is as, if not more important. So I'm going to finish there, and I apologize for going on the next 5 minutes.